Building Block 6, Population Management, a team-based approach to panel management. Population management refers to stratifying a group of people based on their needs and tailoring the care that we provide to those needs. For example, people with complex medical needs require more attention than people who are healthy. One important component of population-based care is panel management, in which a medical assistant, health worker, or nurse ensures that a clinic's entire population of patients receives evidence-based preventive and chronic care services. We call this panel management because the list of patients cared for by a clinician is called the clinician's panel. Panel management relies on accurate empanelment. Empanelment allows us to identify how many patients are actively engaged in care, to balance our capacity and demand as a practice, and to identify subpopulations with specific needs. For a solo provider practice, all patients are considered automatically empaneled to that provider. Whether in a solo provider practice or a multi-provider one, accurate empanelment enables us to understand the discrete populations we serve. This allows us to more systematically examine and address their care needs. Panel management is a fundamental change in perspective because it is proactive and global. We are concerned with all of our assigned patients, not just those who come in for care. And we are concerned with all of our patients' needs, not just the need that brings them in for a visit. Panel management is generally done in primary care, but also pertains to specialty practices. A practice can decide which panel management activities to focus on by using data to identify and prioritize opportunities for improvement in its preventive and chronic care services. Some examples include: have all patients in our primary care clinic between 50 and 75 years of age received colorectal cancer screening at the appropriate time intervals? Have all diabetic patients in our primary care clinic had laboratory studies of HbA1c, LDL cholesterol, and urine microalbumin at the appropriate times? Have all patients in our nephrology specialty practice had kidney function tests done at appropriate intervals? Note that you don't have to do everything at once. Panel management can be as simple as choosing one goal, such as improving the rates of flu vaccines or mammograms. Panel management is important for patients because it can improve care and save lives. For example, if care teams can make sure that all appropriate patients are screened regularly for colorectal cancer, some early colon cancers will be uncovered. Ultimately, this means that finding colon cancer early on can lead to the cancer being treated or even cured. In some cases, panel management could also have financial benefits for the practice. Panel management is associated with improved rates of cancer screening, immunizations, smoking cessation counseling, blood pressure control, and diabetes care and control. Care teams may be getting extra payments for good performance or may be paid less for poor performance. Practices interested in recognition as a patient-centered medical home may be required to carry out panel management. A care gap exists when a patient is overdue for a service that should be done on a regular basis. For instance, according to the American Diabetes Association guidelines, a patient with poorly controlled diabetes should have an A1C test every 3 months. A care gap means that the patient is overdue for the A1C test. This is called a process care gap. We can close the care gap by having the patient come to the lab for an A1C test. A care gap also exists when a patient is above goal for a particular disease. For example, if a patient's goal for diabetes control is an A1C of 7 or below, A care gap exists if the most recent HbA1c is greater than 7. This is an outcome care gap. Outcome care gaps are harder to close. It requires the patient making healthy lifestyle choices and taking medications. Using a team-based care approach, people like medical assistants, health workers, or reception staff can play an important role in panel management. Prospective panel managers can learn to review patient panels, to identify care gaps, and to talk with patients about getting up to date on their care. Patients may be more likely to share their fears or uncertainties about tests with medical assistants than with their physicians, which can make them an especially important member of the care team when it comes to panel management. Because most medical assisting programs do not focus on how to conduct panel management, it is important that staff who are to conduct panel management be trained on how to identify care gaps and talk to patients. For example, if staff are asking patients to use a stool collection kit at home for colorectal cancer screening, they should have an opportunity to examine the kit, to learn how to use it, and to practice answering frequently asked questions and to respond to frequent concerns. While clinicians generally do not conduct panel management, they have a role in the process. They can review patient lists with their medical assistant partner to identify exceptions. For example, people who are frail may have different target values for their blood pressure. People with severe or terminal illness may not be an ideal candidate for certain cancer screenings. 5 things are important for implementing panel management and identifying care gaps: a registry and/or a health maintenance screen on the electronic health record, clinical practice guidelines, standing orders, and trained panel managers. Panel management relies on accurate, complete, and up-to-date information in a patient registry. A registry is a list of patients with medical information about each patient. The list may be all the patients coming to your clinic, all the patients impaneled to one clinician, or all the patients with diabetes coming to your clinic. A registry can be searched to identify patients with care gaps. That is to say, patients who are overdue for things like mammograms, immunizations, or diabetic foot screenings. The registry can also identify patients not in control of their blood pressure or blood sugar. Registries can generate reports on how well each clinician or the entire clinic is performing on these preventive and chronic care measures. They can also generate reports on care gaps for any given patient. Some EHRs have registry capability, some do not. If not, an information technology expert can help the clinic obtain a separate registry that receives clinical information from the EHR and from the laboratory. Many independent physician associations, or IPAs, produce care gap reports for their practices. Many EHRs have a health maintenance screen with a list of routine preventive and chronic care studies such as mammograms, immunizations, and HbA1c tests for patients with diabetes, showing which are overdue. The health maintenance screen is different from the registry. Whereas the registry can be used to identify care gaps for groups of patients, the health maintenance screen, which is a screen within the chart of one patient, only lists care gaps for that one patient. The health maintenance screen and the registry can be programmed to highlight overdue studies, for example, showing them in red. If your EHR lacks a health maintenance screen, it is worth checking with your EHR vendor. For practices without an electronic health record, you can still conduct panel management using a flow sheet. Generally, a flow sheet is a one-page, condition-specific form that allows the care team to track all of the required care for that condition. A flow sheet for a diabetic patient might show the last date and value of their hemoglobin A1C, microalbumin, and creatinine lab test, and last date of their diabetes foot and eye exams. That way, the care team can think about all of the care gaps associated with that condition. Every clinic needs to decide on clinical practice guidelines for preventive and chronic care services and needs to set goals for patients. Without guidelines, you don't know if a patient is overdue for a service or if their values are above goal. For example, which patients should get mammograms and how often? How often should patients with diabetes get their A1C tests, foot exams, and eye exams? What is the A1C goal for patients with diabetes? What is the blood pressure goal? Most clinics use well-regarded national guidelines, for example, from the American Diabetes Association or U.S. Preventive Service Task Force. Some national guidelines are controversial, cholesterol and mammography, for example. Clinics need to decide whether to use those national guidelines or create modified guidelines. The medical director is responsible for creating guidelines and discussing them with the clinicians in the clinic. Additionally, people conducting panel management need to be trained on those guidelines. Panel management is most effective when paired with standing orders that allow non-clinicians to not only identify but also to close care gaps as they identify them using guideline-compliant workflows. Standing orders are written and approved by clinicians in a practice. They allow trained members of the care team to, for example, automatically order standard lab work or tests such as mammography for patients who meet the criteria and are overdue for care. In some practices, most routine care is completed before the clinician even enters the examination room, enabling clinicians to focus visits on patients' concerns, issues requiring the clinician's level of expertise, treatment options, and shared care plans. Last but not least, trained panel managers are an essential component needed to implement panel management at a clinic. As mentioned before, an increasing number of practices are training nurses, medical assistants, health workers, or reception staff for this responsibility. To add panel management to their job description, staff need training and protected time. One important part of the training is about how to speak with patients using simple descriptions and collaborative communication styles. Panel management can be conducted through what we call outreach or inreach. Outreach means reaching out to patients when they are not at clinic and inviting them to come in for care. Outreach is difficult without a registry that has a list of all the patients with their up-to-date clinical information. With a registry, panel managers generate lists of patients with care gaps and perform mailings, phone calls, or email messages asking patients to close their care gaps. Most outreach can be done by sending computer reminders or letters to patients, with panel managers following up by phone for patients who do not respond. In general, registries are combed every 1 or 2 months to look for care gaps and to outreach to patients without scheduled clinic visits. InReach is panel management for patients who are physically present in the clinic. For example, if a patient comes in for a cough, an MA could look at the health maintenance screen and recognize that the person is overdue for a pneumococcal vaccination or a cervical cancer screening. They would then provide the immunizations that day or schedule the patient for the pap smear. When there is no health maintenance screening, MAs may review or scrub charts for the patients who are coming in the next day. Make a list of care gaps for those patients. A brief meeting or huddle at the beginning of the day is a good chance for the clinician and medical assistant to make sure that they are on the same page about the care that is needed. Many practices that are new to panel management or have limited staffing find it easiest to start with InReach. Clinics may provide panel management through a specialized panel manager model or a teamlet model. In the specialized panel manager model, one or two people, usually medical assistants, are trained to be full or half-time panel managers. They conduct panel management, usually through outreach, for all of the patients in the clinic. The advantage of this model is that panel management usually has protected time to conduct outreach calls or send letters. The disadvantage is that the panel manager likely will not have a relationship with the people that he or she is reaching out to, and patients may be less responsive to this person. In the teamlet model at larger practices, every MA is trained to be a panel manager, and every MA spends part of his or her time doing panel management. Each provider is paired with an MA, who is also a panel manager, in a two-person team called a teamlet. The teamlet, not just the provider, is responsible for a panel of patients. The responsibility of the MA panel manager is to provide inreach and outreach only for that panel of patients. When it is possible, a teamlet model can be ideal because the person conducting outreach knows both the patient and the clinician and can more easily communicate around questions that arise. Smaller practices have the benefit of their staff members, including prospective panel managers, being better known to their patients than those in larger practices. In summary, panel management is a proactive approach to providing care to a population of patients that requires having team members such as medical assistants look for care gaps, overdue labs, or cancer screening, for example, and close those gaps based on established clinical guidelines. Panel management can improve care and save lives. It can also improve quality scores and potentially lead to increased pay for performance income.